Right. Good afternoon, everyone. Thanks so much for inviting me out to share a little bit about the work that we've been doing focused on suicide prevention. I do want to clarify, I feel very compelled to do this. I serve in the Air Force, not the Army, so aim high, everyone. But I did get to hang out with the Army while I was deployed to Iraq in 2009. And I wanted to start here because this is actually, in many respects, the origins of a lot of our work that we do now, focused on developing, testing, and refining treatments to prevent suicide. And I don't have time to get into details now, but it was while I was deployed to Joint Base Balad at the Air Force Theater Hospital that I personally started questioning a lot of our assumptions about suicide prevention. And one of the things that many of us psychologists in the military were doing that was really kind of considered crazy at the time was to start treating trauma and suicide risk in very aggressive, intensive formats. And so today we've heard quite a bit, for instance, about like 2-week and 3-week massed therapy programs. But 15 to 20 years ago, while I was still active duty, this is where it was invented, was in a combat zone. Because you don't have the luxury of meeting with someone every Thursday at 3:00 p.m. for therapy for months at a time. Many of us downrange were told, you've got about 3 or 4 days, Captain, and you make a decision. And this person's either going home or they're going back to the fight. And so we started, psychologists and social workers, cramming therapies into very short windows, and we found that it worked. And so I think it's worthwhile that what now for many of us seems to be sort of a status quo mainstream approach to treating psychological conditions amongst military personnel and veterans was actually developed on the battlefield itself. And we're now sharing this technology, so to speak, even with civilians. Now, I'm going to focus on the treatments that are most effective for preventing suicidal behaviors. And one of the first things I want to talk about is the importance of distinguishing between suicidal thoughts and suicidal behaviors. And I think a recent meta-analysis that was just published within the past few months really does a very nice job of highlighting why we need to think about suicidal thinking and suicidal behaviors as different outcomes. And this is because different treatments have different effects on suicidal thoughts and suicidal behaviors. And so a couple of rules or overall trends from what we know now based on decades of published research is that, first off, the treatments that most of us are familiar with that were designed for mental health diagnoses like depression or anxiety disorders, things like that, although they might be effective for reducing suicidal thoughts and psychiatric illness, they do not necessarily prevent people from trying to kill themselves. And so what this means is that one of the things we've learned is that most of our traditional treatments are not actually well suited for preventing suicide, even though they might be reasonably effective for helping people with a variety of mental health conditions. A second key takeaway is that treatments that effectively reduce suicidal thinking do not necessarily prevent people from trying to kill themselves as well. And I recall now a kind of a moment, maybe from 10, 15 years ago now. I happened to have the luxury of being on a scientific review panel with Marsha Linehan, who's a very well-known suicide prevention researcher who did a lot of pioneering work amongst people diagnosed with borderline personality disorder. And I remember in true Marsha Linehan fashion, if you knew her, she was trite, she was pithy, she was sarcastic, she was irreverent. And during this panel, she said, well, I mean, the truth is, pretty much everything helps people feel better. Some treatments just save their lives. And it was this really, I think, standout way of summarizing the literature that there are only a handful of treatments that actually stop people from trying to kill themselves, at least that we know of thus far. And the leading candidate, what we know the most about, is cognitive behavioral therapies. But what we know now is that CBT by itself is not good enough. It needs to be CBT that is directly tailored for the transdiagnostic underlying mechanisms that give rise to suicide. And so this has been a big focus of my research for the past 15 or so years since separating from the military. And to date, brief cognitive behavioral therapy for suicide prevention, or BCBT for short, is the only psychological treatment that has ever been shown to reduce suicidal behaviors amongst military personnel. In a clinical trial that we conducted at Fort Carson with active duty soldiers now over a decade ago, what we found was that soldiers who received BCBT were 60% less likely to attempt suicide during the 2-year follow-up as compared to soldiers who received standard routine mental health care offered from the Defense Health Services. And we have since replicated these findings in civilian samples. A study conducted by our team within the past year shows that BCBT also reduces suicide attempts when it's delivered via telehealth, remotely to individuals. Our motivation for doing this study, of course, was COVID. And earlier this morning, someone asked the question about, like, do we use Zoom or virtual options for delivering care? And 5 or 6 years ago, almost all of us said, oh, hell no. But now it's fairly routine operation. And it used to be the rule was it's too dangerous to do virtual remote therapy with suicidal high-risk individuals. And so what did we typically do in that situation? We typically offered no therapy at all because that was seen as less liability inducing than providing evidence-based care remotely. Tides have changed quite a bit, and we now have scientific evidence showing that we actually can prevent suicidal behavior via video teleconferencing technology. We're also now working on adapting the BCBT model to be more flexible for a wide range of settings. Another very recent trial just published within the past few months took the BCBT protocol, which is typically 10 to 12 outpatient therapy sessions, so about 1 hour a week for 10 to 12 weeks on average. They said, well, that's not really practical in a psychiatric inpatient setting where most people are only on a unit for 72 hours to 96 hours. And so what Gretchen Diefenbach and colleagues did was they took a handful of procedures out of the BCBT protocol, 4 total, and said, what if we did this every single day while someone was on a psychiatric inpatient unit? And the dirty little secret about suicide prevention is that before this study was published within the past couple of months, there has not been a single research study ever showing that psychiatric inpatient hospitalization prevents suicide. On the contrary, we see increased risk for suicide following psychiatric discharge. And indeed, the highest risk time in someone's life is the week after they're discharged from an inpatient unit, where their risk is 300 times increased for dying by suicide as compared to prior to their hospitalization. And so what we saw in the Diefenbach study is that this adapted, streamlined BCBT protocol reduced suicide attempts by 60% post-discharge as compared to treatment as usual. One of the interesting things about this study is that the control condition, the treatment as usual, included procedures and interventions that are now considered quote unquote best practice for suicide prevention, namely suicide risk assessment using standardized tools, as well as safety planning. And so we are outperforming what is currently considered best practice for suicide prevention. We've done research as well. I mentioned with this inpatient study where we've taken things out of the therapy and tested them in abbreviated formats. We've also looked at one single procedure from BCBT called crisis response planning that actually incidentally served as like the inspiration for safety planning interventions. And we've tested this in military personnel as well and found that this 30-minute to 60-minute conversation and structured intervention by itself will reduce suicide attempts by 76% as compared to standard crisis management procedures. We recently replicated this in a sample of military personnel and veterans who were suicidal and found that when we added this one thing from BCBT to trauma-focused therapy, we got faster reductions in suicidal ideation and again, a 50% reduction in suicide attempts. So the magic number now is about 50 to 60%. We just keep seeing this over and over and over again in our studies. I could share with you a preview of research to come. We're now wrapping up another randomized clinical trial funded by the Department of Defense. And all of the veterans, all of the military personnel are now done with therapy, and we're just in follow-up assessment. And some of the preliminary findings that we're seeing is now, once again, 60% or more reduction in suicide attempts. And so we're now starting to move into a new phase of research where it's like, okay, we know this works. It's way better than everything we pit it against. And so can we make it work even better? Because 60% is great, but I'd like to get to 70% and then perhaps 80%. And so why might this be? Why is it that BCBT is doing so much better than other treatments, to include other interventions and treatments that involve these so-called best practices for suicide prevention? Well, I think it's related to a handful of things. As I mentioned at the start, the first thing we do in BCBT is we distinguish suicidal behaviors from suicidal thinking. This is, believe it or not, still kind of a revolutionary idea. Amongst suicide researchers, we tend to think of suicidal thoughts as like a low-risk form of suicidal behaviors, or as the sort of gateway by which people eventually arrive at suicide. But there's actually a whole host of research suggesting that thinking about suicide and trying to kill yourself, they have different correlates, they're associated with different processes, and they probably involve different drivers and different mechanisms, which is probably why they respond differently to different treatments, right? So likewise, we need to distinguish suicide from mental illness. To this day, the predominant way that mental health professionals approach suicide risk reduction with their patients is to diagnose them with one or more mental health conditions from DSM and then treat the disorder. The idea being that suicide risk is a symptom of mental illness, and so if we treat the mental illness, suicide risk will resolve. That's actually not supported by a lot of research. Suicide is something different from diagnosis. And so it has independent risk factors, independent drivers. And so in BCBT, we sort of put diagnosis to the side and say it doesn't really matter what the constellation of symptoms are. We really need to go right at the things that are pushing you to want to kill yourself and do something about that. We're also learning that collaboration and route of delivery matters a lot. So I think this is most salient in some of the newer research looking at crisis response planning as compared to safety planning. As I mentioned, we're now consistently getting better results than what we see with safety planning. And I think it's related to route of delivery, where a common way that we approach suicide risk management with people is we give them a form, we say, fill this in and take care of yourself, come up with some coping skills for yourself. But what we're learning is that actually maybe is not the most effective way of helping people to develop customized, highly tailored plans that can sort of inhibit their forward motion towards suicide. And some of what we're finding now increasingly fascinating is that there's a lot to be said about things like therapeutic relationship, about the bond between a clinician and their patient, about the trust that can be built. And these sort of ideal outcomes like inducing empathy, feeling heard, feeling understood can actually be promoted with very simple strategies that require us to set aside what our compliance officers are telling us to do. And so putting the standardized checklist to the side and sitting with someone and saying, tell me your story about being suicidal. And tell me about the day that you tried to kill yourself. And using that information to now construct and develop a highly personalized, tailored treatment plan that is also routinized in a protocol format. And then finally, something that I'm increasingly interested in and have thought about is this importance of specialized care pathways. And I think of this because at The Ohio State University, we have a clinic, a suicide care clinic that's combined with our trauma care, program, collectively known as Strive. And what we find is we get way better outcomes when we adopt a specialized care model, where we've moved away from the general outpatient, the general mental health care approach. Instead, we have specialists, which mirrors how we approach this in other medical disciplines, and say that suicide risk is different. It's not a general mental health issue. It actually is something that requires a high level of training and specialization. And so we have these highly specialized clinics now where patients are referred to us, they receive aggressive focused treatment using BCBT, and then they can be returned back to the general outpatient clinic or the referring provider for ongoing services. And so we do have, I'll make one final pitch and plug here. This is our area of expertise. Someone asked me earlier, how are we sort of differentiated or different from some of the other veteran-focused programs around the country? And I would say what we do best is suicide prevention. We take the veterans that the other programs deem too risky and too dangerous for care. And so if you are in any of those programs or any other setting and you're not sure what to do because you have a high-risk veteran, call us. We can enroll the veterans in our mini research studies, but we also have multiple healthcare providers, psychologists who are PsyPACT credentialed. So we now can reach into 42 states via teletherapy, and more states are coming on board all the time. And so here is my personal email address on the right-hand side, and then our group's email address and contact information on the left. So thank you so much for inviting me out today and joining you today. And I'll conclude there. I think I'm at time. So thanks, everyone.